Hi, my name is Noelle Webster, and I'm presenting the information on emergency department waiting times and streamlining the process. As we all know, emergency rooms across the country are often bombarded with patients that have waited hours or even longer to be admitted, even by seen by physicians. And even more ends up leaving without being treated at all. Um, the ED function is impeded primarily because of the number of patients that are waiting exceeds the physical and staffing capacities that we have. The American Hospital Association reports that 69% of urban emergency departments are over capacity that often result in ambulance diversions and crowded conditions. Um, Emergency room staff are often confused at what exactly their roles are because their roles change every day or every minute. And it keeps a level of frustration because a lot of times there's no space and equipment needed uh, that are limited. Um, as a result of the long waiting times, the staff dissatisfaction, the patient satisfaction plummeting, the quality of care has been compromised. From 1995 to 2009, annual visits to the emergency room in the U.S. have increased from 96.5 million to 136.1 million, which is approximately 41%. At the same time, the number of emergency rooms have decreased by 27%. So we have more people coming into less buildings. I think by utilizing patient flow, appropriate triage methods, and interdisciplinary support, I believe that most emergency departments would be able to thrive and give patients satisfactory care and attention. And the facility where I work as an RN is located in an environment in which there are a lot of immigrants who don't speak English and don't have access to health care, to health insurance. As a result of this, the emergency department is often treated like a primary care physician's office or urgent care office. I would want to implement a patient partner role that be responsible for greeting the patient in their native language, perform a mini registration, nothing complicated, name, date of birth, any allergies, and their chief complaint. This process will take approximately 4 minutes to cut down the time in triage and also makes the person feel welcome and that someone who understands them and understands their language is there to help facilitate the process. Now, the triage process is the most important one because it allows us to categorize the patients by the level of acuity or how sick they are. So, a study showed that the five um, level process of triage is most effective. So, say you had a person who was a level one. So, they were stable, they were non urgent care. We would probably, you know, direct them to an area of which there were nurses and physicians there to treat them on site and release them back home. I would have a section of the triage for people like this who have non emergent conditions to be treated by nurse practitioners and a lead physician. A study recently showed that 45% of people who were seen in triage by a nurse practitioner or physician were discharged home. That's almost half of the population that's coming into the ER. That would hugely decompress the emergency department as well as decrease the waiting times of people. If a patient is discharged from the emergency department, I want an area that's developed in which has three things: registered nurses, case management, and discharge kiosks. Registered nurses would be there mostly to implement and educate any discharge instructions and medications. The case managers would be there to assist in follow-up clinics or resources that the patient would need. And the discharge kiosk would serve those the patients who don't have any health insurance as a way to sign up for health insurance or any public assistance programs. If the initial triage process by the physician or nurse practitioner showed that the patient was more acute, then the patient would be sent into the main ER in which an interdisciplinary team would be waiting for them. The team would consist of a pharmacist who would be responsible for collecting home medication and allergies, phlebotomist for immediate lab draws, an EKG technician if needed, imaging, an emergency room tech, which would be responsible for getting the patient an IV connected to all monitoring devices, maybe they're on telemetry. A nurse and physician would then be assigned once in the main emergency department. Once the patient was in a room or a bay and they were stable, Then at this point, bedside registration would take place. If the patient was deemed to be admitted into the facility as inpatient or observation, the time from admission order to inpatient bed would be 30 minutes, is what we call throughput time. The ED nurse would send a real-time electronic handoff document to the receiving nurse on the floor that would include medications administered, admitting diagnosis, health history, and vital signs. It would then be the ED nurse's responsibility to call the floor nurse and say, hey, I seen this information. Is there anything else that you need? And at that point, the additional information would be communicated and the patient would be transported directly to the floor. The same handoff would be required for the physician. The lead hospitalist would receive the information from the ED physician and assign the receiving physician and communicate the appropriate information. Once arriving to the inpatient bed, there would be two designated admission and discharge nurses on each unit. The admission nurse would be responsible for the admission assessment, verifying medications and allergies, ensuring patency of IV, orienting the patient to the unit, advanced directive information, and verifying vaccines. That would not only streamline the admission process, but it would alleviate the stresses of the floor nurse because she would already have patients that she's caring for. In conclusion, examining our current practices and rethinking how flow, triage, and implementation of interdisciplinary teams will impact patient satisfaction, patient safety, and also it would decompress our already overcrowded emergency department. This would decrease the risk for adverse events, mortality rates, and this would decrease on the number of people who would leave without being seen by a caregiver. In order to commit this project, there would have to be huge support from administration as well as leadership for the emergency department. Not only would this streamlined process benefit patients, it would allow for staff to better know their roles and responsibilities and increase morale. Thank you and have a nice